can you move fast and break things in healthcare? And to what extent can we do that in pediatrics? Because it's sort of already happening, right?
To your question, right? So George has one word that he says over and over again: relationships. And the reason that they're big super group works is because they're very focused on the relationships, and they have partners. So the partners, like a marriage, a good marriage, complement each other. And George is a very curious, constant learner, while Jim is
Academic.
more academic, more conservative. Show me the data. Show me where's that. He needs to understand why this is going. So it balances things out. And in the podcast, George is more reserved, and I'm a bullet train with two machine guns on top. I don't take prisoners. And George can tell you our coaching meeting this morning, right? It was an hour where I just basically fired at everybody and told them what I want done by the end of the day, because we need to move. We can't just talk about stuff. It needs to get done, and we need to get it done now. And that's just who I am. That's why I don't fit in the health system, because
you would fire number one.
I am a disruptive physician, because I walk up to the CEO's office, knock on the door, and like, you don't have an appointment. Like, I need to see him now. And I walk right in, and I say, look, you can't be doing this, because someone's going to die, and it's going to be a kid, and it's be really bad for you. You're going to get fired along with me. Want to go for that ride? And you bet he picks up the phone, or she picks up the phone, and chews somebody out below, and the problem gets solved. But after about the seventh time you do that, they start looking for a way to make you leave, because you are making more work for them.
Yeah.
They want quiet, steady bonuses.
They want sheep.
So yes, we need to disrupt. How are we going to disrupt? I think it starts with educating young physicians. And I mean young physicians, medical students that are interested in pediatrics, teaching finance of their own households, so they're not, up to their eyeballs in debt, and how to run a practice. Because I do think, like George, that the best practices are physician-led or physician-owned. And if you let go of that, then it becomes all about the money, and the innovation is about how to improve the margins, not how to improve care. But we have fallen, because and I know why we are. I tell people this all the time. If I did anything that Cosmopolitan magazine says on your kid, I'd be a witch doctor. I wouldn't be a physician. So we're trained to be slow and cautious in medicine, to look at what our forefathers did, what worked for them, what didn't work for them, and to follow in a conservative way, and not to change practice until we have the studies that prove that it improves outcomes.
The problem I've had with that is, I don't know your experience, but my experience in COVID is that families were drowning. And it was really difficult to be a child health advocate during that time and be seeing families. So it actually felt to me like there's real urgency, and we cannot be conservative and wait for data. There are ways to be thoughtful, responsible, and evidence-based without waiting for randomized controlled trials on every single detail, right?
Right. So tell me, what did you do? You were in the practice, I think, at that time, right? During COVID.
Yeah. So I was.
Tell me about your practice that day, and I'll tell you what we did.
Okay. Well, we were a community practice. Most of our families were in network, meaning they were employees at Stanford Hospital, working parents away from their extended relatives. So when everything closed, literally everything closed, and we were part of we were just one small pediatric, 14 doctors, but pediatric practice in the setting of a large adult multi-specialty group. So the prioritization of peds in general wasn't great, right? I think we were sort of viewed as a referral base, essentially. And so when everything closed, I think the adult doctors felt comfortable with that, because adults had access, I think, to the emergency room. And I guess that felt less, well, I can't really say what that felt like, but me, when I'm speaking on the phone with my my first responders who are going to work and their children have a fever, it didn't seem right that they should go to the emergency room. And so I led our practice's COVID response. And again, we didn't have recommendations. And I was, we were waiting for, remember those days we were waiting for papers to come from China or something to describe the virus. What does it look like? I was reaching out to the infectious disease folks. I was reading past papers on epidemics and pandemics and how those were handled. And so we designed a COVID clinic actually in our practice and continued seeing patients the whole time. And it was just a series of really exceptionally difficult administrative challenges. Tell me about how your experience.
So before closed.
So George,
closed down, right?
Before you go there, tell me about the kid that you, Sabrina, that you met in the parking lot with a fever.
Oh gosh.
And what happened the next day? Because I think that exemplifies corporate medicine.
It really does. And it was the nail in the coffin for me, quite frankly. So I had a full day of clinic and my wonderful nurse came to me at the end of the day. She'd been putting out fires all day. And she said, this mom called at 8:30 this morning. I just haven't been able to get back to her. Baby has fever, 3-year-old, 18-month-old, something like that. And I said, fine. It was like 6 o'clock. I was trying to get home for family dinner. I'll call her from the car. So I'm driving home. I'm speaking to this mom. It's clear to me that this child has a fever. If the child is not seen and checked, for instance, for like an ear infection, then that kid's going to end up in the emergency room. So I said, all right, well, meet me in the parking lot. The clinic's closed, but I'll examine the baby and we'll just keep you out of the emergency room tonight. So I turned around and went back to the parking lot at our clinic, examined the baby. What I told the mom is now almost 3 days of fever. I said, if the baby still has high fever tomorrow, you need to come in and we have to do a urine. And so call our office. And so I went back into the office. Everyone was gone. I sent, the way you're supposed to do it. I sent staff messages, I charted, and I left Post-it notes, which is the ultimate way that we communicate in medicine, right? So in addition to all the formal ways of communicating, I put Post-it notes on my nurse's desk saying, FYI, I'm not going to be here tomorrow, but this patient may be calling or maybe coming in if they have fever. And so the next day I start getting frantic phone calls from people in the clinic saying, this mother just walked into COVID clinic with a fever, which, by the way, I designed the way that we get into clinic. So they couldn't have walked in with a fever. I mean, they certainly could have been triaged at the door. But regardless, I think the mom's impression was my baby has a fever, I'm bringing them in. And so that was their first issue. And then they just couldn't figure out how to get this kid in for a catheterization. And ultimately, I don't know, 5 or 6 people ended up calling me, everyone with ruffled feathers, for a problem that struck me as really very simple. We'd done visits for catheterizations regularly. Then ultimately, there was an investigation that was launched by HR to look into how something like this could happen. And what that told me is that I can lead my family dinner and do what I think is best for a patient, but the system still can't do what's right for the patient.
Correct. It's called bureaucratic medicine.
Corporate medicine.
Corporate medicine. So what we did it all. We didn't shut down 1 hour. All right. We put people that had vacation on vacation so they didn't lose money. The other people that were around would see the patients. We saw everybody. We divvied up the office, well side, sick sides. We saw people with fevers. We did COVID tests. When it was time to get COVID tests, we got the COVID test. When it was time to get the COVID vaccine, we got the COVID vaccine. We just saw a problem and we resolved the problem.
And you saw people in tents, right? Parking lot.
So fast forward, everybody's talking about, oh my God, people are vaccinated. They're going to be vaccine delayed. They're not coming in for the checkups. We started to smell that people don't want to come into the building when they're healthy. What did we do? We went to Costco, bought an 8x8 tent, put it in the parking lot. We did a telemedicine visit with them from my office. So they're in the car. You do all your stuff that you got to do, order all the stuff you got to order, give the referrals that you need to do, give all the refills that you need to do. Then you say, I'll meet you in the tent. You go into the tent, examine the kid. The nurse comes afterwards, give them the shot, interaction, 3 minutes, 5 minutes, however long it took outdoors. Was it great medicine? No, it wasn't great. I mean, it was good enough. It was better than nothing.
Yeah, but it was necessary.
It was third world medicine.
Yeah.
But it worked.
And it was better than the emergency room.
Yeah, better than the emergency room. We never sent anybody to the emergency room.
Yeah.
So Sabrina, when you tell that story, the first thing that comes to my mind is I love you.
Yes.
You are what I think of a doctor. You will drop dinner with your family to take care of a patient. You will answer the phone call. You will go home and worry about the patient. You will do what's right for the patient. You're just in the wrong place. You're in corporate medicine, and corporate medicine doesn't value doctors that put the patient first and foremost and humanity in the exam.
Right. Thank you for saying that. But I actually think, I mean, I'm not in that practice anymore because of that and many other experiences like that. But what I am doing is at Stanford focused on reimagining how we can deliver pediatric care so that it puts the patient and the family in the center. And so I look at practices like yours, Dr. Rogu, and say, what does the future look like? So right now you have the skills to run this practice.
Yes.
Do you think it's sustainable? Tell me about the business of your practice and how you think it's going to translate into the future.
Well, back in the COVID times, I had the Dr. Rogu part of me that had to do work, right? I had to take care of the patients because I thought it was the right thing to do. Also had to take care of the physicians. You can't put them in harm's way. We had to get them the mask and all the stuff that you need. And then besides all the medical stuff, practice owners, we had to sustain the practice. How do you generate income if people are not coming in? How are you going to pay all that vacation time? So you have a lot of hats.
And most doctors do that.
Most successful physician owners do that very well. And
do you think they do? That has my experience. It feels like those are two really different hats to wear.
Most successful physician owners do that very well. And we hear it over and over and over and over again. How happy they are, how well they do, how satisfied they are with the care they give.
Yeah.
But you have to want to,
Not easy.
And where we have fallen short is we have not educated younger generations of physicians, again, including medical students, on how to run a practice and how to run a business and how to finance stuff. And that is one huge opportunity, because you're right. So George has a younger brother as a partner, and he has a son in medical school. So it's a family business, right? So everybody's learning the ropes as they come up on the food chain of the family business. If you don't have a younger brother and a son that's in medical school, then you have to hire physicians that want to make a difference and are willing to roll their sleeves up, run a practice, run a small business, and start teaching them from day one.
I have medical students that come with me every month for 10 months. I have a different student every month. I got tired of looking for physicians. So we figured we'll grow our own. There has to be a kid from Long Island that goes to this school that's going to go into peds. I have 10, 4 other doctors have 10. So there's 50 bodies that go through our building a year. Somebody's going to go into peds and want to go into private practice, and we're teaching them. And our practice rotation has become the most popular rotation at their school.
I can imagine that. That sounds amazing.
And I mean, let me just share some of the success stories that George has had, right? So we do some data analytics, and he had a student who has to be South Asian. He's an engineer, and the kid's a whiz at math. I mean, just a whiz. And now is going into medical school, or is in medical school, right? And he looked at some of our dashboards, and this kid could not stop playing with it. He couldn't believe that a small practice and, quote unquote, a pediatrician understood data and could program software to show the data that a practice needs to run. And he had the best 30 days of his life. He was learning pediatrics and he was using all the math he learned in engineering school.
And he got a mini MBA.
He got a mini MBA, so much so he said he might come back for another
He might come back. He's coming back as a 4th year. And he may even go into pediatrics. I don't know. But I told him if he does, he's welcome. And he's from Long Island.
Right?
I feel like there's an elephant in the room, and I would love to get your 2 cents on this, but I do a lot of work in the digital health space. I talk to a lot of founders, mainly they're entrepreneurs or tech-oriented people who had the experience of becoming parents and realize how difficult our system is. And so I've created solutions for children and families. And my observation is that they are getting traction with families because it may not be the case in your practice, George, but in the vast majority of practices, I think that families and patients in general find it difficult to reach their doctors, difficult to get questions answered, difficult to understand what needs to happen. And so there's a need, right? So these companies are going direct to consumer. And my fear and my anticipation is that it's going to cannibalize somewhat the pediatric medical home and the relationships and expertise that we're able to offer families. And so my thesis has been we need to work with them and collaborate to the extent that that's possible. But I'm curious how you think about this.
Herb, take a stab.
I think everything starts with humanity and relationships.
Yep.
If there are tech platforms which allow me to quickly better communicate with the families of the kids I take care of, that helps the problem.
I would call that physician enablement, right?
Yes.
Like enabled solutions. Yeah.
But if it's something that is sold as a solution to a problem, technology is hardly ever a solution to a problem. It helps or enables humans to solve problems.
Right.
But
What's that?
we're never going to replace relationships with machines.
No, but we can power them, don't you think?
Yes. And
Yes.
that's where the money is going to be, is to create solutions that make it so. So I always give this example. I don't need to see a backup throw culture being negative and sign off on it in an EMR. It's a waste of my time. I don't need to see a negative urine culture. It's a waste of my time.
Yeah.
When I had the urgent care, my nursing staff would sign, date it, call the parent, and put it away.
That's efficiency.
We already
That's
had an
efficiency.
We already had an EMR, so they noted in the EMR, urine culture came back from Quest, negative. Call the parent, child's doing better. Right? Well, we could do that with AI. I don't, it drives me nuts when I go in clinic on Fridays and I go through 30 negative throat cultures and urine cultures. Why am I wasting my time on that? Let me spend that time taking care of someone else. Right? So definitely if you could find AI that does it, why are physicians coding? It's a waste of my time. Let me spend those extra 2 minutes with the patient.
Well, I would argue that there are many more things that we could use technology to augment.
Yes.
Aside from those, but that the essential problem for pediatricians is that there's no bandwidth. There's no bandwidth, A, to co-develop them, and B, to integrate them into our workflow. And I've seen this played out in conversations with founders over and over, that they find it impossible to reach pediatricians and to be able to co-design and collaborate on their innovations. And, I remember being in practice, seeing 25 patients a day. There's just no time to breathe, much less to find and validate a new tool in your existing workflow. Right? So how do we solve that?
Well, I think you have to start like how we started, right? So we have a CEO coaching class. A lot of great ideas come out of there, right? But it starts with a relationship and a conversation. If you want to get founders with pediatricians who are, one, tech savvy, and two, willing to test different things without breaking, nobody wants to break their train, right? Because that's how you make money. but they will try things that, might improve the timing of the train. They just are going to say, if it's going to totally stop, we can't do it." But these people have to get together in a room and have a mastermind and understand what the friction points are on both sides, and then come back the next day and do it for another 4 hours. And again, understand what the friction points are on both sides and see who develops a relationship with who that they can collaborate on, a project. And unfortunately, there has to be money on the table because doctors make money by seeing patients. They're not in the dream world of a lawyer where I'm going to win a $20 million settlement and 30% of that is mine. They're not in the tech space where if I sell this company for $5 billion, 500 million of that is mine.
Yeah.
We see patients every day, but it's doable. George has done some tech experiments in his practice to help, corporations that they're starting technology and using it.
Yeah, George, can you share some of your experiences with that? Have you done pilots?
I get called on advisory boards for everybody for some reason. And everybody thinks that they have a great thing, but sometimes it's not practical. It's not usable. It'll get in the physician's way and the doctor won't use it. From telemedicine to EHRs to different interfaces and platforms, front end, back end. I mean, they always, many times with a piece of product or something, you'll get a company that wants to implement the product in your practice. The doctor will say, go talk to my manager. The manager will decide whether that product is good for the practice for the doctor to use. They do everything. They do all the work. They pay all the bills. Then the doctor gets on board. Oh, this is so good. I'm never going to use it. Be gone. What a waste of time, money, and effort because he did not get involved. He should have gotten involved a little bit, looked at it. He would have realized in 5 minutes, this is garbage.
Yeah, but you had
to come out of the exam room, come out of the silos. Did you notice how many times we said the word relationships in this podcast today? I'd say 20, 30 times. That's what's missing. And I think corporate medicine is trying to destroy relationships in all domains.
But corporate medicine is different to startup medicine, which is the other piece that's happening.
Yeah.
So George, you had a good experience when Pedro and Canet came and they tested their vaccine product.
Yeah. No, they had that experience was they wanted to develop a platform to manage vaccines. And the way to do it was through COVID because everybody wanted COVID. So they came to me to help work you to put it into our office. So I expected them to have a product already developed and fully operational. Little did I know that the tech companies usually develop it as they go along. So I helped them to develop it as they went along. So we had the patients, the this, the that. And over time, they made a really good product. But a physician wants that product to be fully good the moment it hits my office. I don't want to build it for you.
Yeah.
But that's where it's different brains that are working. The tech company where they develop it as they go along, and the doctor that wants it perfect.
So why did you decide to work with that company?
Because I thought it was the right thing to do. They were doing a noble thing with COVID vaccines. They helped us to develop for our clinically integrated network to be able to get a lot of the Pfizer vaccine, to take it and to redistribute it to other smaller practices within our clinically integrated network. So they did all the tech inventory and the management of that and helped to connect to the state to get it approved. So where we could either say, oh, there's too many vaccines to give, so we can't give COVID vaccines, or we can do something about it. So they wanted to do something about it. I wanted to help. We got it together. So in my community, in our clinically integrated network, I can go down and say, we did the right thing and we gave vaccines to children.
So would you say that there are other problems similar to that you would be interested in collaborating on a solution to develop?
Oh my God. You know how many podcasts we can make with this?
Well, that's what I'm interested in, actually.
Oh, yes.
I think there are many opportunities for this, but I think it's hard to reach pediatricians because we're so busy.
Yeah.
So I have two thoughts. So another pain point in this discussion is that a lot of these tech solutions don't integrate with these smaller EMRs. And so you might have the most beautiful tech solution, but it's just a totally other silo. And then it doesn't work with an EMR. Or, the hospital here is ECW with Children's National. Well, Children's National doesn't want to spend the money to integrate it into ECW. So it just creates more work for me, for my staff. And that's always a big point. There's lots of great solutions out there, but they live in a different silo than my EHR. And so that's another pain point for the practice to incorporate. And that's a really difficult one to crack because the EHR companies, they want to make money. And so they focus on the problems that will make them money, not integrations.
Well, that's a good topic for a podcast right there. We should do this once a month.
But
I think PMR integrations is a very interesting, especially as it relates to pediatrics.
Yes.
Yeah.
So I think it'd be a great idea if you wanted to do a podcast once a month, Sabrina, with us, focused on innovation and invite your people from Silicon Valley.
We'll make your topics.
Yeah. I love it. I love it. You guys. So here's what I wonder though, after this conversation is that you guys have a very strong point of view. It feels like in terms of your vision of pediatrics, of sort of ideal pediatrics. I'm not really sure. I think I either have my own strong view or I'm a little less committed to one. No, I think I'm just a little less committed to one model, which I know is sort of like apocryphal to, the pediatric community, that there should be anything but this one model. But I don't know. I'm really interested in exploring how we can empower this relationship between pediatricians and patients, but decrease the friction to getting all the necessary data and analysis that we need.
Right.
So is that something that you guys are open to?
Yeah, sure.
Yeah.
It starts with community, right?
Yeah.
You're not going to solve a lot of these problems unless you're part of your community of relationship.
Yep.
The further you get away from the community and the relationships, the less effective you become if you're trying to help people. Now, if I'm just trying to make money on Wall Street, doesn't really matter where I'm sitting. I have a computer with 5 screens, and I'm screaming every time one of my bets goes down. But there's no relationship between me and my Apple stock. That we don't talk, we don't go out for coffee. Apple stock doesn't tell me about their kids. No, but we're in a relationship-driven business, and we're in a community-driven business. And as soon as we get too far away from that and lose our humility, we're done.
Yep.
I agree with that. Can I just share one last thing?
Yes.
I want to share an example because I just think it's a good illustration of how these digital health companies can actually be really beneficial. When I was in my practice, being in Silicon Valley, my patients are early adopters. I'm an early adopter. And so they were always bringing solutions to me. And I was always learning about things and trying them out with our patients. And there was one in particular called Curbo Health. Do either one of you know that?
No.
So it was started by a local woman in Palo Alto whose son used the Stanford pediatric weight loss program, which is very labor intensive. The family needs to come to clinic on the Stanford campus once a week for, I forgot how long it is, but for a significant amount of time. And he benefited greatly from it. And so she's an entrepreneur. She said, well, how can I make this more accessible to more people? So she licensed their evidence-based weight loss program for children and created an app called Curbo, which she then augmented with weekly coaching. That was sort of an add-on service. And so I heard about it early on and I started offering it to families sort of as an add-on to conversations. When that was a topic of conversation in our visits, we would look at it together and say, is this something that would be interesting to you? And by and large, the teens and adolescents were incredibly interested in having something they could engage with on their phone, something that would give them guidance on how to improve their eating habit. And the story of Kerbo is so fascinating because I actually interviewed her already for my podcast, but she found it difficult to be funded. And she found it difficult to collaborate with pediatricians because, again, they were so busy. And the funding piece is that the majority of venture funders didn't get it, didn't really understand why what the value prop was here for families. And ultimately, she sold it to Weight Watchers.
Yes.
And you may have seen in the press, there was an enormous backlash once that was announced that there should be any sort of weight loss interventions for children. And it's a cautionary tale and an interesting story, I think, about all the different unique barriers to creating something good for children using technology.
Yeah.
But it can be done.
It can be done, but
You just have to get the right people in the room.
Correct. Relationships.
And it's not going to be one time, it's going to be several times.
Yep.
Until people come up with, they build trust, they build relationships, and then, they prove that things work.
Yeah. All
Well,
right.
this has been a wonderful hour. Thank you
Yeah.
for guest hosting. And
thanks, guys.
I
We'll pick
think
it
we
up
should
again
do
in a
this
month.
once a month.
Pick it up again in a month.